Thank you, Corey. I will do my best to get through everything. I know everyone is probably getting tired, but thank you very much. So I'm going to be speaking about immunotherapy beyond checkpoint inhibitors. I think we've heard a lot about checkpoint inhibitors, both today as well as in the last couple of years. But there's more to immunotherapy than checkpoint blockade. We have vaccines, some of which have been mentioned yesterday and today. And of course, adoptive T-cell therapies are another exciting form of immunotherapy for cancer. So the Magritte study was presented previously by some of my colleagues, but this was a vaccine study targeting MAGE-A3. MAGE-A3 is a gene silent in all normal tissue except for the placenta and the testis, active in much of non-small cell lung cancer. So there was this vaccine developed, had MAGE-A3 protein as well as an immunostimulant. The phase 2 study showed uniform humoral responses, acceptable toxicity, though notably no improvement in disease-free survival. And so Magritte was developed, phase 3 study, randomized patients after treatment for definitive intent for localized disease to either placebo or vaccination. And these are the survival curves. I promise there are 2 survival curves there, but they just look like one. So the conclusion, this vaccine failed to improve disease-free survival or overall survival in any subgroups. There were no subgroups with clinical benefit, so they couldn't then identify a gene signature of who benefited. So that was a problem, and so as a result, this drug is not being developed further. But there's another vaccine that, at least according to my Facebook feed, a lot of people are interested in. So this is the Sinovac EGF. This was a vaccine that was developed in Cuba. And it targets epidermal growth factor. So EGFR, which of course we've discussed in the context of EGFR mutation, is also overexpressed in a lot of lung cancer, up to 80%, and there's some data to indicate that EGFR overexpression is associated with a worse prognosis. So this team in Cuba developed a vaccine with a recombinant epidermal growth factor, a carrier protein, and then an adjuvant to sort of stimulate the immune response. They did a phase 1-2 study which showed safety, developed an immune response, which is good, and some hints at efficacy. The way this is administered is every time they give a shot, it's 4 shots. It's 2 in the deltoids and 2 in the gluteals. So it is an intense experience. 200 grams per meter squared of Cytoxan IV given before the dose. And this sort of low dose of cyclophosphamide is thought to be an immune stimulant rather than an immune suppressant agent. So this led to the phase 3 Sinovac EGF study, where they took patients who had completed 4 to 6 cycles of chemotherapy for metastatic disease. Now this is distinct from many other vaccine studies which utilize the patients who have completed surgery. We're trying to increase cure rates. These were metastatic disease patients, and they were randomized to either Sinovac EGF every 2 weeks times 4 for sort of an induction, followed by every 4 weeks until progression of disease, or best supportive care. Primary outcome was overall survival. The vaccine was well tolerated. Not many adverse events. The most common events were injection site reactions, but you've got 4 injections each time. At some point, you're going to get an injection site reaction. There were fevers. There was some shortness of breath. Here were the overall survival data, and you can see that there was a trend towards improvement of overall survival with the Sinovac EGF. And this is interesting, sort of an appealing concept, but I think some of the subgroup and secondary analyses are even more interesting. So they took a look at the circulating EGF, the circulating epidermal growth factor, in patients. And what they identified confirmed what I said before. If you have a lot of EGF circulating in your blood, that's bad. So if you see here, the blue line is patients who have a high EGF, and they have a worse overall survival. And this is the whole population that's on the study, relative to those patients who have a low EGF. But then, okay, it's a prognostic marker, but is it a predictive one? So this is sort of interesting. Now we take those patients who are receiving the Simivax EGF vaccination, and the curves flip. So of those patients who have EGF positive who receive the vaccination, their overall survival is much better than those patients with EGF positive, high EGF, who get control. So here we're seeing a difference if you look at the median overall survival of 14.7 months versus 8.6 months. So this is to me, a clear sign of efficacy for this patient population, and the amount of immunogenicity with this vaccination was pretty good. 79% of patients had a good antibody response. So how exactly they defined that was a little bit hazy in the publication. So how do we apply this information to the US practice? I mentioned that people completed 4 to 6 cycles of chemo. None of the people on this study received maintenance chemotherapy. Maintenance chemotherapy was not allowed. We use maintenance chemotherapy quite a bit. Of note, over 50% of the patients in this study had squamous cell lung cancer, for whom maintenance chemotherapy is not as uniformly utilized. Also, the publication was a little bit unclear about what chemo regimens were utilized. The quote was, mostly cisplatin and carboplatin in combination with vinblastine, etoposide, and paclitaxel. So I don't really know what drugs were used. There's a lot of information that I want to learn. But there is a phase 3 currently ongoing in an international study that looks at a different patient population. They take patients who are EGF greater than 250, which is an interesting cutoff because the 870 was the median on the prior study. So I'm not sure where the 250 came from. And it's given along with, at the same time as cytotoxic chemotherapy. So it'll be interesting to see how effective it is when given along with an immunosuppressant agent. But there are 2 studies that are being developed to open here in the United States. And these, I think, apply more readily to our practice. Now, I know this is a busy slide, but I thought it was important to see sort of the general schema of how they're doing this. This is being led by Kelvin Lee. So for patients in the second-line treatment of lung cancer, they're doing a phase 1 study of evaluating the combination of the Simivax EGF with nivolumab, which sounds more reasonable than a combination with a cytotoxic immunosuppressant. And then in the phase 2 study, they're taking patients who have a high EGF level, greater than 870, just like was seen in the phase 3 study, and combining that with nivolumab to see what efficacy they can reveal. So this study is about to open. And then this is a second study, which I actually am a little more interested in, where they're taking patients who are identified on low-dose CT lung cancer screening. And those patients who have lung cancer, you say, okay, it's got to be early stage, get whatever treatment you want, and then giving them vaccination, similar to how other vaccination studies are done. But then in the second arm, that green arrow down there, take those patients who are getting low-dose CT scan, have some nodule, and say, gosh, something's funky, right? These are high-risk patients, and then randomize those patients to Simivax or placebo as a cancer prevention modality. And I think that that's also an interesting idea. We'll see how these go forward. We're doing some work at Penn using some other ways of administering a vaccine. So we've done a couple of studies now which utilize a technology called Electroporation. And basically what you do with electroporation, we've done 2 studies, one with an HPV vaccine in head and neck cancer led by my colleague Dr. Agarwal, who spoke yesterday, and another study which we're doing right now, which is targeting TERT. And what you do is you inject a DNA plasmid into the skin, an IM injection, and then you administer a small electrical pulse. It's a very generous way of saying it. And then the plasmid, as a result of this pulse, goes into the cells. The cells then go to the lymph nodes, which causes presentation of antigen, and this can lead to quite a robust immune response. We've presented data previously from the HPV study showing very nice responses, and indeed this method of vaccination has also been used in cervical cancer, where it led to regression of CIN 2 and 3 in a large percentage of patients. So I'd like to move on to adoptive T-cell therapies. Now this is something that, being at Penn, I hear a lot about and I have to say a lot about, because that's a lot of stuff that we're doing. But I think there's a lot of mystery surrounding this sort of treatment. Most notably, what exactly it is. I think there's two subclasses of adoptive T-cell therapies which should be discussed. The first is a T-cell receptor therapy, so-called TCR. Now, TCR therapies utilize a native T-cell receptor. So we've identified a T-cell receptor that goes to a target of interest, and we can then put it on T-cells and give it back to patients. This is MHC dependent, so you need to have the right kind of T-cells in order to receive this sort of therapy. It has a relatively low affinity, but it can target intracellular as well as extracellular targets. But because of the affinity and the where the targets are, there are actually many resistance mechanisms. The therapy that we've been doing more work with at Penn through Dr. June's lab is CAR T-cell, which stands for chimeric antigen receptor T-cell. And basically what they do is they then design the whole T-cell, top to bottom. It's a designer T-cell, a designer receptor. And this is MHC independent. It has a very, very high affinity. And because it has a very high affinity only for cell surface targets, we have to be careful about what target we choose. If you choose something that's present a lot on tumor, but also is present in someone's lungs, for instance, that can be bad because of the high degree of affinity and the high activity of these cells. So how do we administer these things? So usually what happens is we have a patient come in, we collect autologous blood, we get out their T cells, we have antibody-coated beads, which are then put in with the cells, we activate the cells, we expand the cells, we remove the beads, we then have a product that we're going to give back to the patient. But one of the most important steps before we give them back to the patient is the use of a lymphodepleting chemotherapy. Now this is something that they use in hematologic malignancies all the time because they do stem cell transplants. In lung cancer, we're not as frequently administering lymphodepleting conditioning regimens. So this is a bit of a deviation from what we were previously doing. But then the T cells get reinfused. So why are we excited about this? This was the big study, New England Journal 2014, and they took CAR T cells that were directed at CD19 and they infused them into relapsed ALL. This is a disease that is deadly and has very few active treatments. They showed a 90% complete response rate with this therapy and a 6-month overall survival of 78%. And for reference, chemo has a less than 25% complete response rate, and it's usually quite short duration. These cells were quite persistent, landing 68% at 6 months, though it wasn't without toxicity. There were 27% severe cytokine release syndrome, people going to the ICU with these problems. So trying to do it in thoracic malignancies, there have been 2 presentations, one from our group and one in China, and what they found was that in the EGFR targeted CAR for lung cancer, they were able to get 2 partial responses, 5 stable disease, and the benefit was relatively short-lived. We did our first mesothelin targeted CAR. We saw no clinical responses, and the T cells went away in about a month. So this is not consistent with the exciting stuff I was saying before. So what are the barriers to CAR T-cell in solid tumors? I think they can really be broken down into the expansion and persistence of the CARs, trafficking the CARs to the tumor, overcoming checkpoint-mediated blockade, and then picking the right target is really essential. You know, if you lose all of CD19 positive cells, well, you don't have B cells. That's compatible with life. Okay? You can still live and not have B cells. But there was a CAR that was targeting HER2 that was associated with significant toxicity, and that stopped that development quite quickly. So how do we get the CAR running? So I mentioned a conditioning regimen, and it's already a component of therapy in hematologic malignancies. But the other thing that we can do is, remember, these are completely designed receptors. So you can change the co-stimulatory molecules. We have the outside, that's the receptor for the target. There's a hinge region, and then the inside is what it's going to do to the cell. And we can modify all three of those sections. So you can increase the amount of co-stimulatory molecules, which you can see as we go from first to third generation CARs. We can also work on the immunogenicity of the CARs, both in terms of how much of an immune response they can induce and how much of an immune response gets attacked at them. One of the thoughts with the mesothelin CAR that we had in our last study was it was a humanized CAR. And it wasn't a fully human CAR, so it was possible that the body was just attacking the cells, preventing persistence. So how do we drive the CAR to the tumor? It's hard when you have signs like this, but the body doesn't have these signs. So each tumor has a chemokine profile, and that directs tumor-friendly cells to the stroma. But if you characterize the tumor, you can actually take advantage of that profile in terms of the design of the CARs. Some tumors, such as pancreatic cancers and some lung cancers, have dense stromal tissue surrounding the tumor that prevents access of the CARs. So we can have the cell release hyaluronase, heparinase, or we can even directly inject the CARs into the tumor, which also gets past some issues with blood vessel formation within these tumors. So how do we take the brakes off of the CAR? We've spoken a lot of taking the brakes off of things today. Once the immune system gets activated, we know that there are checkpoints that prevent downstream effects. So in vitro studies have evaluated, okay, well, we have these checkpoints. They're going to cause a problem. We have checkpoint blockade, right? So we have our receptor, our checkpoint. It's going to put the stop on our T cell. So we'll put a checkpoint blockade antibody, and it'll stop that. Well, that's one idea. But looking at it from a different perspective, remember, we're designing these receptors. So what if we turned PD-1 on the T cell, instead of making it turn an off switch, we could make it into an on switch. And so that is a way to get around that in a targeted fashion without systemic exposure to the checkpoint inhibitors. So in summary, adoptive T-cell therapies are an exciting new treatment paradigm. Those significant barriers do remain, as I mentioned. The next CAR-T study is about to be opened at Penn, which is using a fully humanized anti-mesothelin CAR. I thank you very much.